Hello everyone, myself Dr. Rajesh, Assistant Professor, Department of Cardiac Anesthesia. Today I am going to speak about ventricular assist devices. Coming to the introduction, heart failure is the common pathway for number of disorders leading to myocardial dysfunction. But it is generally treated with medical therapy or cardiac resynchronization or implantable cardioverter defibrillators. But there remains a large group of patients who have advanced heart failure with poor prognosis despite of optimal medical therapy. Unfortunately, the number of usable donor hearts available to perform heart transplantation for these patients has not been increased. Mechanical support devices for circulation such as left ventricular assist devices is rapidly evolving field, and LVADs are efficient devices that assist and support circulation, and they are being inserted in a number of patients with advanced heart failure. Coming to the development of left ventricular devices, the history of mechanical circulation, it all started with the began of cardiopulmonary bypass in 1953 when surgeons started performing complex open heart surgeries. For treatment of low cardiac output after operation with cardiopulmonary bypass, simple pumps for temporary circulatory supports were developed. Coming to the timeline, in 1964, funding for the artificial heart program by the National Heart, Lung and Blood Institute in the US began to support development for devices for long-term clinical use. In 1966, DeBakey and colleagues implanted the first pneumatically driven LVAD. In 1969, Denton A. Cooley implanted the first total artificial heart intended as a bridge to transplantation in a patient awaiting heart transplant. In 1970, focus shifted to develop more biocompatible systems for long-term therapy. In 92, for the first time, Jarvik-7, that is total artificial heart, was implanted as intended permanent treatment. But after 112 days, the patient died of severe sepsis resulting in multi-organ failure. Due to the high rates of complications, the concept of total artificial heart was never established as a real alternative, and to date the proportion of total artificial heart in mechanical assist devices is below 1%. Coming to the evolution of the technology, from myocardial ischemia there might be cardiogenic shock, ventricular arrhythmias and thrombi and embolus. One model is used clinical despite lack of this prospective trials. High rates of the device malfunction and adverse events with early total artificial heart technology slowed development in this field. But to date, total artificial heart outcomes have been inferior to the left ventricular assist devices. The first total artificial heart is known as Jarvik's total artificial heart or Cardiovas TAH. The problem with this is body surface should be large enough, that is more than 1.7 to accommodate this, and also the distance from the 10th anterior vertebral body to the inner table of sternum should be more than 10 centimeters. The size of the artificial heart, this artificial heart has restricted its use to patients with large enough body habitus to accommodate positioning within the thoracic cavity. This Syncardia's total artificial heart was first implanted in patients at the University of Arizona in 1988, and over 1600 patients have now been supported by this, and this is the longest patient support being just over 4 years prior to the successful heart transplantation. Coming to the first generation of left ventricular assist devices, that is introduction of pulsatile flow. The first left ventricular assist devices that retained the native heart was pneumatically powered pumps placed outside the body. So these are known as paracorporeal ventricular assist devices, and this is connected via cannulas that pull blood by vacuum from the LV into reservoir and return to the aorta in a pulsatile but asynchronous manner by pneumatic power. It has 65 ml of stroke volume pumping chamber and 2 mechanical valves. Alternating positive and negative air pressure generated by a console or portable pneumatic driver produces a beat rate up to 40 to 110 beats per minute and flow rate 1.3 to 7.2 liters per minute. This design dramatically, next is HeartMate XPE. This design dramatically reduced the size of the portable drive unit compared with the paracorporeal ventricular assist devices and allowed freedom of activity. The next significant evaluation in the field was development of HeartMate vented electrical LVAD. The size of the device limited its use to patients with larger body size. The device had significant problems with bearing wear and durability, with a very significant percentage of patients require device placement. This is video depicting of HeartMate when HeartMate 1 is being used, drawing blood from left ventricular apex via diaphragm graft into a reservoir and pumping it again through a graft to the ascending aorta. This is the picture depicting how the ventricular assist device is placed and how the two conduits are placed at the left ventricular apex and one is connecting to the ascending part of the aorta. Next is Novocor. The Novocor LVAD was implanted in over 1600 patients for duration up to 6.1 years, but has been discontinued after trials showing high rate of stroke. The greatest, coming to the second generation LVADs, the greatest advance in the field of LVAD therapy was the change from pulsatile to continuous flow design. Unlike the first generation devices, these continuous flow pumps have only one moving part, the rotor, hence are much more durable. They are also smaller, quieter, and hence surgically implantation is generally less traumatic. Continuous flow pumps also have smaller drive lanes and hence tend to have lower rates of drive lane infection. In this comes the HeartMate 2. It is a continuous flow axial blood pump with internal rotor, and it weighs around 350 grams, approx 7 centimeters in length and 4 centimeters in largest diameter. It can generate up to 10 liters per minute of flow at a pressure of 100 mm Hg. Blood flow through here, as you can see, blood flow through an inflow cannula from the apex of the LV to the pump and returns back through the outflow through an outflow cannula to the ascending aorta. The degree of improvement in outcomes with the continuous flow design led to the total discontinuation of production of pulsatile HeartMate vented electrical LVAD by 2010. Next is Zarvik 2000. This is also a continuous flow axial blood pump, and the whole pump will be sitting in the LV cavity itself as shown in the figure. The pump weighs around 85 grams and measures 2.4 centimeters in diameter and 5.4 centimeters long. The pump can generate up to 7 liters per minute of flow. The next is Berlin Encore. This is also a continuous flow axial flow pump, and it is marketed only in Europe but not in US. In this, as the blood passes through the Encore, it first passes as an inducer that directs laminar flow onto the impeller, which is suspended by a magnetic bearing and floats free of contact with other parts. Next is third generation left ventricular assist devices. These are centrifugal pumps that have been designed for their long durability, compact size, optimization of blood flow through the device to minimize the risk of thrombus formation and hemolysis and simplified surgical implantation. The durability is anticipated to be 5 to 10 years. In this comes the hardware. This is the first LVAD to be entirely contained in the pericardial space, eliminating the need for pump pocket. This uses a centrifugal rather than axial flow design, as well as partial magnetic levitation to suspend the rotor, eliminating the presence of bearings in the bloodstream. The pump weighs around 140 grams with an external diameter of 53 mm, and it spins at 1800 to 4000 rpm, delivering up to 10 liters per minute of blood flow. Next in this is HeartMate 3. This is also a fully magnetically levitated centrifugal flow device that is inserted into the apex of the LV. It spins at 3000 to 9000 RPM and generates up to 10 liters per minute of blood flow. It incorporates rapid changes in rotor speed to create an intrinsic artificial pump pulse, asynchronous with the native heartbeat, to reduce the stasis in the pump. Coming to the percutaneous LVADs, these are another recent advance in the field of LVAD therapy, as has been the development of devices designed to provide urgent or temporary circulatory supports, that is for days, for patients in cardiogenic shock. The first temporary LVAD, temporary ventricular assist devices, was the intra-aortic balloon pump. Extracorporeal membrane oxygenation, or else ECMO, is another temporary VAD which provides a form of support akin to cardiopulmonary bypass, capable of supplanting both cardiac and pulmonary function. Subsequently, the tandem heart, which drains blood from the left atrium via transeptal approach, and the Impella device, which drains blood from the left ventricular and returns it to the proximal aorta, have been introduced. Coming to the indications, bridge to transplantation. The purpose is to provide circulatory support to transplant eligible patient with heart failure with reduced ejection fraction until a donor's heart becomes available. As a destination therapy, who are ineligible for those who are ineligible for cardiac transplantation, the newer devices with improved durability have shown increased survival rates in this category of the patients. Coming to the bridge to decision, LVAD has been used as temporary measure in patients with end organ dysfunction due to heart failure. Stabilization of hemodynamics with improvement in renal function, nutritional status, and reduction in pulmonary hypertension can help make them transplant eligible. Coming as a bridge to recovery, this provides temporary ventricular support in some heart failure patients, has shown to improve myocardial function and promote recovery. There are few strong indications for either BTT or destination therapy or bridge to recovery or as follows, and all must be applicable. The patient should be at least NYHA class 4 for 60 to 90 days, and maximum tolerated medical therapy and certified respiratory therapy or implantable cardioverter defibrillator should be implanted. Chronic dependence on inotropic agent should be present. EF should be less than 25. Pulmonary capillary wedge pressure should be greater than or equal to 20 mmHg, and systolic blood pressure less than or equal to 80 to 90 mmHg, or cardiac index less than or equal to 2 liters per minute per meter square, or evidence of declining renal or right ventricular function. Contraindications are right ventricular dysfunction, either primarily or right heart failure, not secondary to left heart failure. Improper function of the right ventricle leads to insufficient filling of the left heart, which may lead to inadequate inflow into the device and ultimately device malfunction. The second is acute cardiogenic shock with neurological compromise. Without adequate higher function, LVAD placement is not recommended, as it would only increase morbidity and decrease the quality of life. Coexisting severe terminal comorbidity such as either renal, pulmonary, liver or neurological diseases or evidence of advanced metastatic cancer are considered contraindication. Patients with bleeding, that is active bleeding or thrombocytopenia, or confirmed heparin-induced thrombocytopenia, not just bleeding but also the inability to be placed on anticoagulation, makes this a contraindication. Coming to anatomical factors, hypertrophic cardiomyopathy or a large ventricular septal defect are a hindrance to device placement and function. Coming to technical limitation, body surface area less than 1.2 to 1.5 meters square or any other factor. Coming to important is social consideration. LVAD management requires a high degree of patient's compliance, which necessitates adequate psychological function to comply with medication and device maintenance. It also requires family education in interpreting basic function and alarms. Thus, any difficulty posed by such factors could pose a contraindication to LVAD placement. Coming to complications, First is hematological. Bleeding is the most common complications occurring in both the perioperative period as well as later due to need for anticoagulation. Bleeding may occur due to leak at the pump site from polyester grafts in the conduits, the GI bleed from mucosal surfaces and intracranial vessels. The target INR is usually between 1.5 to 2.5. Thrombosis is another significant hematological complication, and patients may develop pump thrombosis, embolic events or even stroke. Hemolysis is another possibility due to technical complications involving the design of pump, malposition cannulae or development of heparin-induced thrombocytopenia and pump thrombosis. Coming to right heart failure, anatomical changes after following LVAD placements causes right ventricular geometric alterations. With this, as with the left ventricular unloading, the septum shifts to the left. The increased cardiac output from the LVAD results in an increased venous return to the right ventricle, which now has improved compliance. However, in patients with chronic heart failure, there is pre-existing pulmonary hypertension. This can result in right ventricular failure. Coming to the infection, most commonly the gram-positive Staphylococcus aureus is isolated, but Enterococcus and other Staphylococcus species may be present. The most common gram-negative organism is Pseudomonas aeruginosa, and infection usually occurs at the pump site, pump pocket or driveline. Coming to neurological complications, stroke is one of the most dreaded complications of LVAD placement. Both ischemic and hemorrhagic strokes are known to occur either immediate postoperatively or after several months. The risk of hemorrhagic stroke is due to anticoagulation, hence a fine balance is necessary to achieve optimum anticoagulation. Coming to arrhythmias, ventricular arrhythmias are common after the procedure, and this is due to the cause of re-entering circuits after the placement of cannula, and suction can lead to contact between the cannula and ventricular septum, triggering the arrhythmias. Management with variety of medications is usually successful. However, refractory cases require catheter ablation or device exchange. This is a diagram depicting various complications, where T is the timeline where the complication may occur, and R is the treatment and DX is the diagnostic methods, where such different complications such as stroke, aortic insufficiency, where the even transcatheter wall repair or closure should be done, and right heart failure, pump thrombosis, driveline infection and GI bleeding as discussed. Coming to the physiological changes after left ventricular assist device placement. After the restoration of systemic cardiac output with an LVAD has profound effects on end organ perfusion, especially the kidneys and the liver are as assessed by normalizing serum levels of creatinine, bilirubin, liver enzymes and other markers. Improvement in organ functions are sustained for years to months, and VAD use seems not to significantly affect cerebral autoregulation, although this is based on a small trial. LVAD implantation results in pressure and volume unloading of the left ventricle. This reduces LV size with some improvement in the function at a global level as measured by improved ejection fraction, and at a microscopic level as evidenced by reduction in myocyte size, collagen content and myocyte tumor necrosis factor alpha levels. There are also reductions in circulating levels of catecholamines and neuroendocrine hormones that reflect improved hemodynamics. Heart failure results in downregulation of beta adrenergic receptors in response to an adrenergic overload. This results in a reduced responsiveness to the exogenously administered beta and alpha adrenergic agonists to patients with advanced heart failure. LVAD implantation can restore beta adrenergic receptor density and reverse this downregulation. Whereas most patients getting an LVAD are in biventricular failure, with up to 1/3 manifesting some degree of RV failure after LVAD implantation. Only 10% require RV support. Unloading of the left ventricle results in RV afterload reduction and improvement in diastolic ventricular interdependence, favoring the right ventricle. Right ventricle remains susceptible to ischemia, injury, and failure after LVAD implantation, and needs careful handling during anesthesia to maintain flow to the LVAD. Coming to the right ventricular failure with a left ventricular assist device. Right ventricular failure is always a risk with left LVAD support. LVAD output increases the preload to the right heart. Susceptibility to RV failure and ischemia must always be considered. Coming to the mechanical circulatory support for RV failure. One of the earliest acute RV support devices was a PA balloon counter pulsation pump, which was limited by the need for surgical implantation and variable effects on the RV afterload. In the early 90s, rotary flow RV assist devices (RVADs) demonstrated hemodynamic superiority and better clinical outcomes compared with PA balloon counter pulsation pump for acute RV failure. Preload and afterload are major determinants of flow through rotary flow mechanical circulatory support devices. Device flow, determined as Q, is directly related to rotations per minute of the impeller and indirectly related to the pressure gradient between the inlet, that is preload, and the outlet, that is afterload of the impeller. The pressure gradient, that is difference between the afterload and preload, refers to as pressure head, denoted as H, varies during the cardiac cycle. For LVADs, the blood is drawn from the LV and pump it to the aorta. H is lowest during the ventricular systole when LV pressure is greatest. Conversely, the pressure difference, that is H, is highest during the ventricular diastole when LV pressure at its lowest. Accordingly, because flow is inversely related to this pressure gradient, LVAD pump flow is maximum during systole and minimum during diastole. These dynamics are readily appreciated from the HQ curve of the map. For our coming to the RV support devices, that the blood will be drawn from the RA and pumped into the PA, the dynamics are fundamentally the same, but because variations in RA and PA pressures are not as great as in LV, variations in RVAD flow are generally significantly less than for LVADs. In case of RV failure, the most MCS systems will include cannulation of the RA and PA to deliver flow into and out of a continuous flow pump respectively. The pressure gradient, that is H, in this case is determined by RA pressure, that is preload, and PA pressure, which denotes afterload. For patients with severe RV failure resulting from acute ischemia or impaired contractility, the difference between RA and PA pressure is often small, and therefore for fixed rotations per minute, device flow will be high. For patients with RV failure caused by severe pulmonary hypertension, the difference between RA and PA pressure may be large, and for the same rotation per minute settings, device flow will be low. In the contemporary era, where surgical RVADs continue to use extracorporeal centrifugal pumps such as Centrimag pump, and RA to PA cannulation with either a thoracotomy or an open sternotomy can be done. Surgeons have begun to use commercially available LVADs, including the Jarvix and Hartware devices, in the RV position to support isolated RV or biventricular failure. A major limitation of this approach is the operating HQ curve for the surgical LVAD is better suited for the systemic circulation with higher pressure and resistance. Furthermore, because RV tends to operate in a lower pressure, less resistant and more compliant system, surgical LVADs connected to the RA and PA may be more prone to suction events. To overcome this limitation, operators have placed gap spaces to reduce protrusion of LV inlet cannula into the RV and restrict the outflow graft of an LVAD by up to 50%, thereby increasing resistance to VAD outflow at the level approximate the systemic circulation. Coming to the Hartware MVAD, that is miniature ventricular assist device, that has been unique outflow port that originates at 90 degrees angle from the impeller, thereby functioning in part like a centrifugal flow pump. This the miniature size makes it potentially suitable for RV and biventricular support, which has been tested in preclinical models. This is not approved for clinical use in the United States. The other one is the Circulate Synergy device, which is also a miniaturized hybrid axial centrifugal flow pump that has been evaluated in preclinical models for RV and biventricular support. And this video is depicting the pump. And coming to the classification of acute mechanical support devices for right ventricular failure, they may be either direct bypass, they may actively directly bypass right ventricle, or they may indirectly bypass right ventricle. The devices which directly bypasses RV are Impella, Tandem RVAD, Protect Duo, and which indirectly bypasses VA ECMO. This chart depicts various device characteristics and hemodynamic effects of various devices such as Impella, VA ECMO, which are also used in biventricular failure. And this is the proposed algorithm for right ventricular acute mechanical support device used in RV failure. When patient presented with acute RV failure, early diagnosis of RV failure and also assessment of LV function should be done, and treatable causes should be evaluated. If the patient is having refractory arrhythmias or hypoxemia, a patient may directly be placed on VA ECMO, or else rule out. After this, you have to rule out pericardial disease. Acquired hemodynamic data should be obtained with PA catheter. Preload should be optimized, adequate inotropic supports and pulmonary vasodilator should be added, and mechanical ventilation should be optimized. If still the patient is have worsening hypotension or unresponsive, and heart plan assessment should be done by heart team, and should initiate acute right ventricular mechanical circulatory support devices. And if there is anticipated need for oxygenator, then should be placed on VA ECMO or Tandem RVAD, or else the patient can be placed on Impella or Tandem RVAD. If the patient is still unresponsive, worsening pulmonary edema, a patient can be considered for adding LV support also. Thank you.